now moving on to our next speaker is Dr. Franklin Jose, an ID clinical pharmacist specialized in antimicrobial stewardship at SRM Medical College and Research Center. He did his fellowship in antimicrobial stewardship at Christian Medical College, Vellore, and has worked as a clinical pharmacist at SIMS Hospital, Vadapalani, Chennai. I feel proud to welcome such an experienced person to our conference. He'll be sharing his thoughts on antimicrobial stewardship with us. Over to you, Doctor.
Thank you, Santosh. Thank you for your kind welcome and good evening, one and all. And I think I can directly go to the topic. I wish this session to be a discussion session, but just a minute. Yeah. Is this presentation is visible?
Yes, sir. It's visible, sir.
Oh, fine. Actually, today, what I'm planning to talk is what is antimicrobial stewardship and how an antimicrobial stewardship program can be implemented in a healthcare sector, in a hospital setting. And these are the contents which I'm going to talk today, from introduction to and why antimicrobial stewardship is important and its evolution, core elements, and what are the things which is necessary to needed to implement an antimicrobial stewardship program in a hospital setting. And this is an introduction. And anyone can tell what is stewardship actually? Sorry, just is this visible? I'm not sure.
Yes, sir. It's visible, sir.
Okay. Can anyone tell what?
Appropriate use of antimicrobials.
Yes. Just a minute. I have some. Sorry for the interruption. Just give me a minute. Is this visible now?
No, sir. The presentation is not visible.
Okay. And I cannot able to see the comments. I can't because it is in a full screen. So please, if anyone answers something, kindly help me to say the answers. If possible, use your mic to say the answers. And stewardship is actually stewardship is a term meaning of a careful and responsible management of something. Anything is stewardship, and in which antimicrobial stewardship we are going to take care of antimicrobials, a careful, responsible, and management of antimicrobials. And antimicrobial stewardship program is a systemic approach to implement an antimicrobial stewardship in an hospital setting. And it's nothing but assessing the patient and giving a right antibiotic with the right patient, the 5 rights which everyone know, I hope so, right antibiotic to the right patient at the right time and right doses. And I would like to say about the evolution of antimicrobial stewardship. When an antimicrobial stewardship has been emerged, that I wish to show, and this from 1940 to 1970, this is usually called as a golden age of antibiotics, because this is the period from 1940 to 60 is the period actually the most of the antibiotics which we are currently using, like streptomycin, vancomycin, and most of the cephalosporins, methicillin. These drugs has been introduced in the market during the time of 1940 to 60s, and so it is called as a golden age of antibiotics. And alongside during the period, and resistance has been started to evolve from 1945 itself. Dr. Dale and Fleming has identified the resistance to penicillins. And from 1980s, I don't know how many people have heard about Dr. Dale and Dr. McGowan. Dale, he has recently passed out in the March 23rd of 2024. Those two, and Gowan is a micro epidemiologist, and Dr. Dale is an infectious disease physician. Though those two are the people who have made several researches on the antimicrobial resistance and what are the steps can be implemented to prevent or reduce this resistance. And in the 1997, SHIA and IDSA, they have published a guidelines for prevention of antimicrobial resistance, and that's the time the antimicrobial stewardship actual term has been coined and it has been established. And later in the 20th century, in 2000 to 2015, IDSA and SHIA, and along with CDC, they have implemented several guidelines and how to approach an antimicrobial stewardship program to an hospital setting has been introduced from 2007. And now, as everyone knows, it becomes a global need, and it is a mandatory thing to be in a hospital setting, and especially in a country like in India. Why antimicrobial stewardship?
What is
As we all know, because of the resistance, and WHO has said that recently they have said that antimicrobial resistance is the top 10 global threat in yeah, along with climate change and um, and it is estimated that in 2019 alone, around 1.27 million people deaths globally and associated with 4.9 million deaths. And WHO said that antimicrobial stewardship, along with infection prevention control, these two are the main things to reduce the antimicrobial resistance. Not just an antimicrobial stewardship only won't help, and it should be in. It is like a two pillars of to reduce the resistance. Infection prevention control is also one of the most important factor to reduce the antimicrobial resistance. And this is the data about the India. India actually globally India is called as the antimicrobial resistance capital of the world because we stayed in the fourth highest position in the world of antimicrobial consumption behind China, US, and Brazil. And it is estimated that in 2000, as per the 2016 study, around 410,000 children's age less than 5 only die with pneumonia due to multi-drug resistant organisms. And in 2008, they did in ICMR did a study, and 29% of isolates of Staph aureus were methicillin resistant, and in 2014 it has been increased to 47%. And after this 2014 into 2016, UN General Assembly had a discussion along with WHO and many top global developing and developed countries. In that, they took a decision. It is a threat. Antimicrobial resistance is a threat, and India is also part of it. So they took a decision to fight it. And in 2017, India has announced the National Action Project on Antimicrobial Resistance. And we can recently see many of the even newspaper articles and social medias are talking about the antimicrobial resistance. And this is the timeline which I have to show to you. You can see when the starting in 1928 when penicillin has been discovered, it took around some 12 years to found a penicillin resistant Staph aureus. When you see this chart, it slowly, it becomes at the end, it becomes in 4 years, 2 years, the resistance start to develop for the new drugs. And in the recently, ceftazidime avibactam is the last drug which it has been found resistance within the same year in 2015 itself. That's how fast the antimicrobial resistance has been growing, and that's why people are considering it as a threat. And these are the goals of an antimicrobial stewardship to optimize the patient outcome, reduce antimicrobial resistance, and to minimize the adverse effects, obviously, and to lower the healthcare costs, monitoring antimicrobial consumption, and promoting education and awareness. And now we can see and how an antimicrobial stewardship program can be implemented in a hospital setting. What are the things we need to implement an antimicrobial stewardship program in an hospital. And an antimicrobial stewardship committee. The committee is it can be an integrated committee with the which is available in hospital, like an infection prevention control or a DTC committee or anything, or it can be a standalone committee. But the committee should have a chairperson who has a sound on the authority, like a medical superintendent or a dean, or any head person who have the power in the hospital. And because it is to an antimicrobial stewardship program, it requires lots of manpower and lots of resources to facilitate that a person who has an authority is needed in the committee. And a obviously we all know, and a microbiologist and a pharmacist and and an ID physician and a surgeon and an infection prevention control team. If an hospital have an infection control prevention team, it is better, or at least an infection control nurse should be in the team and in the committee. And this is the AMSP team. A committee and a team is actually a different thing. A committee is to facilitate the things, is to plan what are the things can be done to, and a antimicrobial stewardship team is the actual persons who are going to work on the field, like ID physician, a microbiologist, a pharmacist, nurse, and a surgeon. These are the people which are going to implement the stewardship program which has been planned by the committee. And I hope so you all know the roles and responsibilities of every person. As we know, physicians are the leaders of the antimicrobial stewardship team. They can provide the diagnosis, and they can support the development of antimicrobial guidelines. And clinical pharmacist, if a clinical pharmacist can be a co-leader, even if a hospital setting doesn't have an ID physician, the clinical pharmacist can be a leader, and they can lead the team of antimicrobial stewardship team. And the clinical pharmacist will help in optimizing the doses and or doses, frequencies, and to monitor the ADR, the dilutions, and the pharmacokinetics and pharmacodynamics, which are a major role in antimicrobial treatment. And microbiologist, obviously, for the lab reports, diagnostic testings, and regular updates on antibiogram in the hospital, in the institutional setting, resistance rate, everything the microbiologist can support in that way. And an infection control specialist, this mostly can be an nurse or an infection who can monitor the hospital acquired infections and rate of spreading of multi-drug resistant organisms and everything. And a nurses and a data analyst. Data analyst is antimicrobial stewardship is actually how to say, you have to measure the consumption of antibiotics, and you have to visualize it so that only you know how much it has been improved, how much your effort has been given an output. So and data analyst is required to show the output of the consumption. And IT technology, information technology is very helpful in the terms of I hope everyone know every hospital will have their own software for patient medical records and everything. And information technology in an antimicrobial stewardship program, they can help to create softwares which can actually monitor the hospital infection, hospital acquired infections, and to put an alert on when to stop or when to start an antibiotic. These things can be even if the patient has been shifted to any other wards or anything, whoever the physician is taking care of the patient, to know whether this has been mentioned, this alert has been mentioned to the person, and IT team is very much needed. And these are the core elements, some 6 core elements which we are going to see in detail, which is as we know, core elements, it is very helpful to these are the things which are mandatory to implement an antimicrobial stewardship program. Leadership commitment, as I said, a chairperson like a medical superintendent or a dean, and a antimicrobial stewardship identified as a priority for a healthcare facility management. The institution first should agree that it is needed, and institutions should support the stewardship program. To implement an effective stewardship program, the institution should first support it financially and technically. Financially means, what I mean financially is to hiring a man support, and as I said, information, IT technologies, or any new forms, or any new contents or data, anything to be done, and the leadership committee commitment should be there. That's why we need a authorized authority person in the committee to make it easy, and accountability and responsibilities. And the antimicrobial stewardship should have a leadership, as I said earlier, an ID physician or a pharmacist. Anyone should first lead the team, and the team should have at least a weekly basis or a monthly basis of meetings along together to know what they are doing and how the prescriptions has been audited, and to sort of the problems. The team should have a meeting. So it is a responsibility uh, uh, to be a team and to work together, and collaboration between antimicrobial stewardship and as infection prevention control programs. The infection prevention and antimicrobial stewardship together only can reduce the antimicrobial resistance. Not just an antimicrobial stewardship just alone cannot. I hope so. And regular activity reports, and antimicrobial stewardship actions. These are the thing a pharmacist and ID physician can work on. Evidence-based standard treatment guidelines, and the hospital should have a list of approved and restricted antibiotics, which the WHO has announced as an AWARE classification: access, watch, and reserve antibiotics. I hope you all know. And and an institution should have unrestricted and approved antibiotics based on their antibiogram, based on their institutional resistance rate. The institution should have a approved and restricted antibiotics. And antimicrobial team should conduct regular ward rounds. This can be a team ward rounds with an ID physician, a clinical pharmacist, and a microbiologist, and an infection prevention control nurse, or at least an individual rounds. Uh, if an hospital doesn't have an ID physician or a microbiologist, at least a pharmacist should have a regular rounds and should monitor the antibiotic consumption of each patient in the institution. And laboratory and imaging services, it will take care by the microbiology department and microbiological support, and access to IT service, as I said before, and the dedicated prescription chart for antimicrobials, which is one of the most important thing in antimicrobial stewardship program. Most of the hospital doesn't have, mostly any which accredited hospitals have the prescription chart for antimicrobials. It will give a thought to an physician when it is written in its individual paper, individual chart. It will give a consciousness of how much antibiotics has been consumed and whether it is necessary or not. And if it has a separate stop date and everything, it will give a little thought to the physician where it should be stopped. If the chart already have a resistant, what is the organism available, what is the resistance rate, what is the creatinine clearance of a patient in the chart, it will help the physician to make the antibiotics use appropriately. Because I don't know how many students are there and how many clinical pharmacists to people actually working seeing this presentation. Actually, people working, they know, mostly in a hospital setting, the doctor, most of them doesn't aware, it is not stopped, and even without the doctor's awareness, the drugs might be continued in. If it is in a regular chart, it will go like continue like other drugs. So if an antimicrobial chart has been a separate chart, it will be helpful for the physician, and it give a great impact on reducing the antimicrobials. And education and training program, this is also one of the most important thing in core elements. The antimicrobial stewardship team first should have an initial, and they should have a regular training on the new updated guidelines. What are the things about hospital acquired infections, how to assess the hospital acquired infections, and what are our hospitals restricted and access antibiotic policy, what is our hospital antibiotic guidelines. These training sessions should be regularly, should the antimicrobial stewardship team should have, and other basic trainings like what is the optimal and other training sessions to the every healthcare professionals like physicians, nurses, and even people who are working as housekeeping and ward boys, everything, to know about the hand hygiene and how to, and for the physician to how to choose an antibiotic, what are the optimal antibiotic choices. And most of the times in wards and in ward and in a setting, mostly the residents will taking care of the patients. Not most of the time, the consultants won't available on the most of the time. So there is the residents are not much. Even the consultants might aware about the what is gram positive, what is what if the resistance, what drug we have to choose. But most of the time, the residents doesn't aware about that, and they have a like protocol, like if it is a gram positive, and in our department we will write this. If this is a gram negative, we will write this. They have that set of mindset. So it is essential to teach everyone in the hospital about antimicrobial stewardship and what is the importance of antimicrobial stewardship. Monitoring and surveillance, monitoring appropriateness of antibiotic use at the unit, and this is where a clinical pharmacist actually work. A clinical pharmacist is the person who actually go to rounds and monitor the antibiotic usage, and monitoring the how much the quantity has been used, and more and how much the intervention. This is also one of the important thing. How much the interventions has been accepted by the physician, the antimicrobial stewardship interventions. And you can see most of the studies are proving that after the education and training program, the acceptance rate of the suggestions has been improved. That's why education is also important for the physicians. And reporting and feedback, whatever we do, if we have to know whether we are doing it right or wrong, we should have a feedback, and we should have a regular reporting and feedback on the from the physician side, from the surgeon side. If we are taking care of a surgical prophylaxis, we should have a regular feedback from the surgeon side. Is there any increase in mortality rate? Did they feel anything, or any patient, is there any increase in infection rate after the stewardship? If there is there any improvement? These kind of feedback and these kind of conversations with the prescribers will improve their trust on the stewardship team. And antimicrobial stewardship implementation strategy. These are the two strategies which mostly followed in antimicrobial stewardship program. Front end strategy, back end strategy. Front end strategy is usually done by a physician, pre-authorization and restriction. Like as we said earlier, if an hospital has an restriction antibiotics, except an ID except an ID physician or an physician who is an or an antimicrobial stewardship team, others cannot use it more than a 1 or 2 doses. If it is used, if they have to use as per WHO policy, as in restricted antibiotics like vancomycin, polymyxins, colistins, and linezolid. If in a hospital, if any physician of any department is want to give a drug, want to give any antibiotic in the list of your hospital antibiotic policy, they should get an access to the ID team. So if they send a referral, or if they invite an antimicrobial stewardship team, the team will come on the next day, and the team have to review the patient, or an ID physician should review the patient. Is this drug is actually necessary to the patient, or we can go for any lower end antibiotics itself enough. And they will first analyze the patient, and they will suggest that primary physician, no, we can give this, or we can just omit, and we can go for a lower end antibiotic itself. That is a pre-authorization and restriction. And backend strategy, prospective audit and feedback. This is actually mostly followed in most of the settings, which is more convenient, and it won't restrict. Each have their own drawbacks and benefits. As in a front end strategy, one of the main drawback is it actually restricts the prescription right of a physician. It is one of the major problem. Most of the physicians won't feel comfortable. And in a back end strategy, where a clinical pharmacist or an antimicrobial stewardship actually can work, a prospective audit and feedback in an antibiotic after the prescription has been prescribed, even if it is a restricted antibiotic, after the prescription has been prescribed, and next the stewardship team or a clinical pharmacist or an ID physician should go and visit the patient within 24 hours to review the patient whether it has been correct, or we can is there any possible to de-escalate or any possibilities to reduce to IV to oral. These things should be reviewed, and we also should make sure whether the antibiotic has been started after sending the cultures. These things should be followed, and if the culture has been sent and in the day 4 review after the culture report came, and again a pharmacist stewardship team or a clinical pharmacist or a physician should go and review the patient. What is the report, what is the culture report, what is the resistance pattern of the organism, and whether should we have to de-escalate or should we have to escalate. These things should be reviewed on the day 4. And day 7, whether day 7 is like whether the patient is improving, the whether a patient is responding to the treatment, and can we stop the treatment. These things can be reviewed with so actually a patient should be reviewed for a week in a back end strategy. And this is like start smart and focus the approach. Like start smart is first, we should not start an antibiotic if the patient doesn't have any evidence of infection, if the patient doesn't have any fevers or any evidence of infection, we should not start an antibiotic. If we are starting, most of the time the physicians was they don't want to take risk on the patients. They don't want, if they doesn't care about the antimicrobial resistance, they doesn't want their patient to get sick. That will be their only concern for most of the physicians. So they don't want to take a risk. They usually give at least one antibiotic to their patients. But in that situation, the antimicrobial stewardship team, as a whole team's data will help. Like what is the antibiogram of the hospital, what is the resistance rate of the hospital, to start an empirical therapy. What in that institution should start. If the institution has an ESBL resistance rate greater than 30% in their institution, they have to start an empirical therapy as a meropenem as an empirical therapy. If the institution has a carbapenem resistance itself greater than 30% in their institution, or in a separate ward or for a separate diagnosis, they should go for empirical therapy itself. They should go for any higher antibiotics like polymyxin or something. It depends on the infection rate of your institution. So starting smartest depends on what is the antimicrobial resistance pattern of your institution. And taking history of relevant allergies, and initiate prompt effective antibiotic as per within 1 hour of the diagnosis of an infection, and comply with local prescribing guidelines. As I said, it complies with the antimicrobial guidelines of your institution, and guidelines is based on your antibiogram, and document clinical indications and doses on a drug chart. And this documentation, as I said earlier, if hospital have a separate antimicrobial chart for antibiotics and antifungals and antivirals, it should have an infective indication. It should have a space for an infective indication. It should have a space for when to stop, when it should be stopped, and it should have a space for the culture reports and resistance and creatinine clearance, patient body weight. These things usually you can't find it in an overall drug chart. So these things are precisely should be included in the antibiotic chart. And include review stop, as I said, include the review and stop date while starting the antibiotic itself. A physician should aware and put, at least, even if it is not stopped, at least to review after 3 days or review after 5 days. These details should be included in the antimicrobial chart, and ensure relevant microbiological specimens taken. and clinical review decision at 48 hours. Within 2 hours, it should be after start. If your hospital is following prospective audit and feedback method, the patient should, after the antibiotic has been started, the patient should be reviewed within a 48 hours, and it should be clinically decided whether it can be stopped, or we can switch it to oral, or we can change it to a more narrow spectrum, or we can continue and wait until the culture report came on. And SWOT analysis. SWOT analysis, I hope so everyone know what is SWOT analysis. It is an assessing whatever we do, we have to assess if your institution is newly implementing the antimicrobial stewardship program or anything. You should have an analysis. What are the strengths in our institution? What are the support systems we have in our institution? What are the weaknesses? What are the problems we have in our institution? What are the opportunities we have to implement the core elements? These and what are the threats? What are the things are more problematic in an institution to implement an antimicrobial stewardship, or which are increasing the resistance rate? Like these SWOT analysis actually based on the core elements which I've said. What are the core elements which if you implement the core elements, you can find what are the things that you're feeling difficult to implement. It might be a human resources, like not having a dedicated staff for antimicrobial stewardship could be a problem in some institutions. In some institutions, there might be no guidelines for antimicrobial. There might be no antimicrobial policy in the institution. That might be a problem in some other institutions. So you should analyze, and you should do a SWOT analysis in your institution. What are the things are positive in your institution? What are the things or you feel weakness in the institution to implement an antimicrobial stewardship program, so that you can further proceed on the weaknesses and threats. Without knowing what are the things a problem, it will help you to work on your weaknesses and threats. And assessing the AMS program. This is like after you're doing your AMS program, everything whatever you do, if you have to measure it to understand the progress, whether it is going worse or it is improving. To know that, you have to assess the program. That's why you're collecting clinical pharmacist or an infection prevention control nurse is collecting the antimicrobial consumption data. What are the antibiotics? Are just giving an intervention is I agree, an intervention can make a great impact on antimicrobial consumption, but without knowing the progress, there is no use. There is no use in giving an intervention. So you should analyze the consumption data by on the regular basis. And these are the structural measures you can assess, like what is the capacity of your institution, what are the systematic supports and IT supports your institution is providing, and what are the like as I said, these things are mostly supported by the committee members, like implementation of essential core elements. What are the things you need to implement the core elements, and availability of guidelines and for empirical, and as I said, if the institution have a guideline for empirical and surgical prophylaxis, and education to healthcare professionals. These are the structural changes. These are the changes which will impact on the overall institution, overall hospital. And process measures, and how patient medical charts are reviewed, how and like these are the processes what you do in the institution, like how the patient medical charts are reviewed, who is reviewing, whether a clinical pharmacist, whether a ID physician, or a microbiologist, or as a team, whether it has been reviewed or not, and the team is having a meeting in a weekly or a monthly basis or not, how antibiotic prescribers and how their users are improving, whether the physicians are following the hospital antibiotic guidelines for empirical therapy, and how much percentage of escalation and orals which there is a possibility to do, and how much we have done in the recent months. and complaints with surgical prophylaxis and hospital acquired infections, the care bundles. The care bundles is also one of the most important thing in a process measure. Like if you have to monitor a hospital acquired infection in your institution, you should follow the care bundle. If you doesn't know what is if you doesn't know the care bundle criteria, the ICMR 2019 guidelines, hospital acquired infections will have a care bundle approaches, how to approach a care bundle, what are the criteria to determine a care bundle. Those are the things you can find it on ICMR 2019 guidelines in hospital acquired infections. And assessing outcome measures or the antimicrobial consumptions, and what is the output of your effort, what is the output of your antimicrobial stewardship in your institution, how much your antimicrobial consumption has been reduced. Those things can be monitored by measured by DDD, and doing days of therapy and length of therapy, and mortality and length of stay, how much the death rate has been reduced in our hospital, how much the patient's hospital stay has been reduced, how much the cost in antimicrobial consumption has been reduced, and clostridial diffusal rates and surgical site infection rate has been reduced. As I said, it will come in the hospital acquired infections and surgical site infections, and how much resistance surveillance. It is a these things. The other things can be measured actually in a monthly basis. You can measure an antimicrobial consumption or length of stay or a clostridium diffusal rate and surgical site infection rate or an hospital acquired infection rate in a monthly basis. But these resistance surveillance and antimicrobial stewardship program, after an effective antimicrobial stewardship program for at least 1 year, you can see the reduction in the resistance rate. So resistance surveillance is also much more important, and it can be mostly taken care by a microbiological department, the surveillances of the resistance. And these are the key takeaways I would like to say. And yes, might mean like microbiology guided therapy should be needed whenever possible, and indication should be evidence based. An ID physician, even an ID physician, is mostly necessary for assessing the patient whether it is actually needed or not, or a clinical pharmacist should aware of the patient. Don't just go try. And one more thing I would like to say is, don't just go and say to the physician, you just read an article, or you just seen somewhere, or just seen somewhere, evidently it should not. Don't just go and it is wrong. Just try to understand from the physician side why they are starting it, what is his point, why he is afraid of to stop this. Always try to understand from the physician side why they have started it and why they are afraid to stop it. Then go for your opinion. If you can, if you say confidently, no sir, the patient doesn't have any fever symptoms, the patient doesn't have any respiratory symptoms, or the patient doesn't require any mechanical ventilation, he is completely stable, and if you feel that, if you have a confidence, just go and say. I always try to understand from the physician side. It is very much important. And narrow spectrum is required. Whenever the narrow spectrum is required, try to reduce it to the narrow spectrum, and dosage appropriate, and the site and type of infection. This is also where the place as clinical pharmacist can actually plays a major crucial role, because the site and type of infections are very much important, and only a pharmacist know the pharmacokinetics and pharmacodynamics very much, and when compared to any other people in a stewardship team. So you are the people should recommend a drug based on the site. Mostly, for an example, if a patient reported a sepsis with any gram-negative bacteria or something, or and the tigecycline shows susceptible, and if a tigecycline shows susceptible, if a physician starts the tigecycline just because it is susceptible, it doesn't work. And it can at least give an synergy. If tigecycline cannot work, but mostly physicians, what they'll do, they'll see the sensitive report, and okay, TG is susceptible. Others, everything are resistant, and TG is susceptible. Okay, I'm going for tigecycline. but the thing is, TG cycline have a great volume of distribution. It won't stay in your blood. It has a greater tissue penetration, so it won't stay in your blood. So giving a TG cycline for a sepsis patient is actually not that much therapeutically effective. These things, pharmacists should know the pharmacokinetics and pharmacodynamics of the antibiotics first, very confidently. Then you can made your interventions to a physician in a proper way, and minimize duration of therapy. When we follow these four things of mind, automatically the patient's duration of therapy we can reduce, and ensure monotherapy in most cases. Whenever possible, try to give a monotherapy. If you don't feel the patient is not very much sick, the patient is stable. If a culture gave positive and the patient is very much stable, we don't want to go for a combination of drugs. We don't want to go for a synergy. Yeah, single drug is enough for a stable. If a patient is very sick, if a patient is in ICU, if a patient is on inotropes, if a patient have a very low BP or something, if a patient is on any mechanical ventilation or anything, in those cases we can't take risk. We can go for a combination therapist. But as much as possible, if you feel the patient is stable, if you feel the patient is very much comfortable, even the culture report shows positive, even the culture report shows the organism, if the patient is stable, go for a monotherapy. It is very much helpful for the patient also, as the cost wise I'm saying. And that's it. These are the things I want to say. I hope I finished. I think I finished. Thank you. And if you have any questions, you can ask. If you have any doubts or anything, you can ask. What's the opinion about report with MAC values making us unable to pick the drug with low MAC values? Is there anything related to stewardship? Yes, actually, MAC values, just by MAC values, you can MAC minimum inhibitory concentration is actually one of the most important thing in treating the patient. But you can't just rely on MAC. If the MAC is low, you can't just give the drug. You should aware whether it is therapeutically effective. As I said earlier, PKPD plays a major role in that. You have to see what is the CLSI guidelines, actual MIC of the organism, and what is the MIC of the patient. You should divide it, and it will give a value whether it is therapeutically relevant or not. You have to go by it. You can't just start a drug just because the MIC value is low. Any other questions? Oh, thank you so much, Preeti. Can I wind up? Santosh, can I wind up, or do you have any other questions? Any audience from audience?
So another question has been from our participant.
Okay. Could you give any insights about AMSP audit, or what kind of insights you're expecting? May I know? As a family intern looking to take clinical pharmacist, what would you be advised if I want to implement antibiotic stewardship in a hospital without one? You cannot sneha mavis. Actually, sneha, that's what I said. You as an individual person, you cannot do anything. What I mean is, you should at least have an institutional support. I'm not saying only as a only person you can't do antimicrobial. We can do a groundwork, like going and seeing the patients, and collecting the data of antimicrobial conceptions, and we can go and see whether it is appropriate. But you should have an institutional support. The hospital should first support support the chairperson like medical superintendent and a microbiologist and an hospital infection control team. You should have a collaboration with those teams in the hospital, and you can do. But as an individual, it depends on a how big the hospital is, how vast your hospital is. It depends. If it is a small setting, if it is a 200 or 100 bedded hospital or a 300 bedded hospital, is yeah, one person or a two-person can do and stewardship. I'm saying it as a groundwork we can do, but and you cannot do it as a single person just without any support I can do. I don't think so it is possible. You should have an institutional support to do an antimicrobial stewardship, and most of the hospitals now giving an institutional support because NABH bring it as a mandatory thing, an antimicrobial resistance in their guidelines to have an NABH. So every hospital which is having an NABH accreditation, they are supporting antimicrobial stewardship. So it is not a big deal to do. Any other questions? And Preeti, I'm sorry. Any insights about AMSP audit? What do you want to know? Can you make it more precise so that I can understand? And template. I have worked in the three different AMSP audits and three web. So I can be able to template, I don't know what you're meaning about audit template. It is what are the main things you have to see in a patient? If you are unable to like as Sneha asked, if you are a single person, you want to do a stewardship, you cannot do if it is not mostly possible in a big hospital setting to do a stewardship in an overall hospital. So you can concentrate on a specific wards which you feel, oh, in this department or in this ward I feel the antimicrobial consumption is irrational or very high, or in a ICU setting you may feel in ICUs the antibiotics are mostly used irrationally. So you can first start with a single department or a single unit as a single person, I'm saying. And what are the things we usually we usually monitor is obviously patient demographics. Apart from the patient, what is the diagnosis of a patient, when the patient has been admitted, and when the patient you have to follow until the patient get discharged. So only as I said in the outcome measures, you are going to measure the length of stay of the patient, the mortality of the patient, and antimicrobial consumption. And antimicrobial consumption, anyway you're going to measure the what are the antibiotics patient are taking. So by you can find it in WHO website what how to calculate the DDDs, how to calculate the DOTs, and how to calculate the length of therapy. These things, there are separate formulas for it. The overall length of stay divided by actual length of, actual DOT divided by the overall DOT into 1,000 patients. You have a formula for it. You can find it in WHO. And sorry, you have to follow the patient from admission to discharge, like what a patient diagnosis, and after the patient admission, did the patient had any fevers? Did the patient had any culture? If the previous culture report came negative after the admission, after 2 to 3 days, patient had a fever complaints, and patient is the culture grows positive, and what are the antibiotics patient is on, from which day to which day antibiotics has been consumed, and whether the patient has been discharged with antibiotics. These things will be helpful in measuring your antimicrobial consumption and patient's outcome. If my interventions aren't accepted by a primary team, I can't do nothing. As I said earlier, first we have to understand from the physician side why they are not stopping. What is their fear to not to stop it? Most of the institutions, they feel their hospital setting is not a sterile, like a patient has been shifted to different wards and anything. Most of the time, the physicians. I'm just saying as an example. Most of the time, the physicians as surgical prophylaxis can be stopped in 1 day is recommended, but in most of the hospital settings, if you see the prophylaxis will go at least for a week to 10 days. When we go and ask for a physician, they would be afraid of no, our hospital is not sterile. I don't believe in that. If they will have afraid because they have to face the patient. They are responsible for their patient. That's their concern. In that way, I'll tell to the primary physician if I found any intervention. If the physician doesn't accept it, I'll just mention it like I'm doing a stewardship for a I'm doing a stewardship. So I'll monitor it, and I'll monitor it like for a month. If a physician is saying no, I'm not gonna stop it. The patient is on risk. Okay, sir, fine. And I'm gonna do an audit for 2 months or 1 month, like in the specific department. The physician concern is like patient might get infection, he might get fever or anything. Then I'll go and monitor the department for a 1 month, like every patient of the department, and how many patients are getting fever during their hospital stay in the department. How many patients are requiring inotropes during their stay in the department. How many patients culture has been sent in the department during and how many patients the culture has grown positive. And you have a you have a committee meeting. You have a committee meeting, right? That's why you need a support, and you can show that if you have a data, you can show that like sir, you are afraid like patient might get infection, but we have found like less than 10% of our patient only getting fevers in our institution, and only few persons are getting positive culture reports, so we can confidently stop it, sir. So your data should speak, we cannot speak it, your data should then speak. What are the parameters we need to focus in de-escalation, sir? Either broad to narrow or number of antibiotics or IV to oral switch. De-escalation. De-escalation is, yes, you said already, broad to narrow and IV to oral switch is the actual de-escalation, as far I know. Both are important, both you have to monitor. I can do a clinical pharmacist in that. Outpatient antimicrobial therapy. That what we can say. It is like it. We cannot. If you have to be a person should be in a pharmacy for it, and we have to review every prescription chart which is coming to the OPD, and why the antibiotics has been prescribed, and you have to talk to the physician, or else what we actually do here in our institutions is we'll monitor the discharge uh, while I'm doing my project in Christian Medical College, which we have found first during the 6 months. The first time while starting the stewardship program, we have observed like the outpatient antimicrobial consumption is high. But once you start giving your recommendations, like you start stopping, while in the hospital itself, when you're stopping the antibiotics, or it is not necessary. Most of the patients, the doctor's not going to prescribe during discharge. So it is like what I feel is it is like part of the process. If you do a stewardship, if you concentrate on the inpatients, the OPAT will gradually it will decrease. I feel so. Maintenance hemodialysis patients should receive prophylaxis antibiotics. Post dialysis patients, I don't think so, Ritik. But before starting the dialysis, the patient usually have an one dose of antibiotic. Any other questions?
So Sriram has actually raised a question previously
Sorry, okay.
in the chat box itself.
What are all the parameters we need to focus in the escalation?
About that, sir. About that.
Yes. As I said, yes, de-escalation is actually two only. You have to from broad to narrow spectrum and IV to oral switch and stop. Those are the things you mentioned too, and both are important. You cannot say only switching IV to oral is the most important thing, and or only broad to narrow, so reducing broad to more. Oh, you're asking what are the parameters we need to focus in
So that question, that's not the question, sir. About that, a
Sorry.
patient was started on empiric meropenem.
A patient was started on empiric meropenem culture shows carbapenem resistant enterococcus and then antibiotics changed to ceftazidime backbone with osteoinfections. This is escalation or de This is an escalation because ceftazidime avibactam is higher into meropenem. So it is an escalation. It is not a de-escalation. Uh, uh, De-escalation is like I'm just giving as an example. De-escalation. If you're sending a culture, if you're sending a culture and starting a meropenem for a patient, and the culture report after the meropenem is going 3 days for the patient. After 3 days, the culture reports come. It is growing in E. coli, which is not a carbapenem, which is not an ESBL, like it is sensitive to every drugs or it is sensitive to third generation cephaloso. Then you are going from meropenem to it is not a resistant organ. So you're from meropenem, you're reducing to only third generation cephaloxacillin or dicloxacillin or cefazolin. It is a de-escalation. But in here it has been started a meropenem. They have started a meropenem and it came as a carbapenem resistance, and you have to escalate it to a higher end, and it is required. It is not a mistake. It is required for the patient, and you are escalating it. And it is an escalation. It is not a de-escalation. If you want to know what is escalation and de-escalation, just have a view on the WHO AWARE classification. What are the access antibiotics? What are the reserved antibiotics? What are the restricted antibiotics? If you started an access antibiotic and then you are going for a reserved or restricted antibiotics, it is a escalation. If you started with ceftazidime or colistin and then you are going for a meropenem, it is a de-escalation. So first make sure to know the AWARE classification and make sure what are the drugs and what are the list in access restriction and watch classification. That is actually escalation and de-escalation. I hope you understand, or should I have to? Yes, thank you for the great session. And this person is my trust. Thank you for opening my place. Question showing has mainly mostly. Meropenem is performed of audio detected after culture report. Neuro was sensitive. The culture report meropenem was sensitive. Patient was prescribed with Cefavi. Neuro stopped. Cefavi continued. Mm, what are we on this patient? OXA48 is positive. And OXA48 is positive and it showed meropenem sensitive. OXA48 origin be sensitive to neuro. As for my knowledge, OXA48 is if OXA48 gene present, it is a carbapenem resistance. It might be microbiological error or I don't think so. I'll go for Cefiv. I won't. If a gene test came OXA48, I'll go for Cefiv. I don't take risk with meropenem. Yes, that's what Ritik. That's what I'm saying. You just as like other physicians, you cannot just rely on the sensitivity report. You just if you can give just because it is sensitive, just because you don't need an antimicrobial stewardship. Then microbiology will give a report what is resistant, what is sensitive, and a physician can start what are the sensitive drugs. That's what the thing in antimicrobial stewardship. You just cannot rely on a sensitive report. You have to take decision based on clinical and diagnostic. Just sensitive, just it is showing a sensitive, I won't go for a meropenem. If it is actually OXA48 positive, I will go for Cefavi. Means we need to prepare and be strong to clear the entrance for ID fellowship in CMC. ID fellowship in CMC, you can what to say. You just be strong in antibiotics, antifungals, and antivirus, and little about vaccines. These things is helpful to clear the exam.
Any more doubts from the participants?
Prior to full dose of antibiotic or just hypersensitivity. If not, what might be reason? No, you can't give a test dose for every antibiotics. Even for like many studies and many guidelines globally, they suggest that for an antibiotic specifically, test dose is not recommended until if the patient is reporting any allergic history of penicillin allergic history in their medical records or medical history. You don't want to. It is not necessary to give a test dose except penicillin. Now even for cephalosporin you don't want to give. If you feel patient is allergic, or if the patient is reporting any allergy to antibiotics, then the test dose should be given. Otherwise a test dose is not recommended for antibiotics. Any views on increasing resistance of cephalosporins to gram positive copy? Increased antimicrobial consumption. What can I say? The always separate antibiotics to which focusing on pediatric population. Yes, I there is a specific specific considerations for pediatric population on based on dosings and frequency dosing guidelines and frequency. There is a specific focus on. So you cannot go like other geriatric or adult patients. You cannot go for pediatric patients. Actually, it is separate thing. I think I don't know which guidelines. Maybe I'll share to the committee people. I think I don't know which national guidelines. They have a separate stewardship policy program for pediatrics. I'm not sure. I forgot the name of the country actually. Essentials of antimicrobial stewardship book by Purba SN help for exam. Any other questions?
So yes, sir, I think that's the questions for now.
Okay. And
Thank you so much, sir, for sharing the
and
knowledge on
okay.
antimicrobial stewardship.
I'm so happy for thanks for the members team members of this Medodrix for taking this initiation.
It was so much. It was very great to have you here, sir.
Thank you
It was
so
such an
much.
interactive session for us.
Oh, thank you, Santosh.
Yes, sir.
Okay, can I leave?
Yes, sir. Sure.
Thank you, sir.
So yes, ladies and gentlemen, as we conclude the first day of Medodrix-Conference on Infectious Disease Pharmacy, I would like to extend my heartfelt thanks to all the participants and speakers, and your participation made this conference so much interesting and very interactive. And I also appreciate your dedication to this critical cause and your contributions today. And we, the Medodrix team, are looking forward to welcoming you back tomorrow for the day 2 of our conference. Please join the conference by 6 p.m. tomorrow to continue our important dialogue and collaboration. Thank you once again. Have a wonderful evening.